Okay, welcome for this past lecture and also part of the MSc course in medical genetics. Today, for the next 50 minutes, I'm going to share with you regarding the expanded carrier screening program and using some of our local experience and case scenario to share with you. So in this talk, the learning objective is mainly on three things. What is carrier testing, and what's the point to note at practice, as well as use free cases discussion to let you understand how the reports look like and what you should be offer for the partners, or what kind of information you have to pay attention to, right? So first of all, what is a carrier genetic testing? Okay, carrier screening actually is a type of genetic test that can tell you whether you carry a gene for a certain genetic disorder. So when it is done, usually it's before or during pregnancy, right? Because we try to avoid these properties to the next generations. It allows you to find out your chance of having a child with a genetic disorder. And in terms of the test approach, it could be targeted. That means targeted on a specific genetic condition, or because now we have next generation sequencing, you can expand from one single condition to a panel of genes that they could be more common in your population, or it's more like a pan-ethics approach that these are all should be taken care globally. So how to choose? Of course, this will also depends on the finance, because when you do a test, it could be very expensive, or it could be relatively cheaper when you do a smaller number. But more importantly is the clinical needs, right? Because if you have a family history related with thalassemia, then of course, the minimum you want to do related with alpha and beta thalassemia. The other thing is also related with psychological issues, because if they have been, encountered with recurrent miscarriage or, unpleasant pregnancy history, there are other issues they may want to consider as well. So in order to understand the test, first we need to put ourselves in the situation of an individual or a consultant, that what is a carrier. Because when you order the test, your result come back, you may have a positive result. Then you are labeled as a carrier. So what is a carrier means? Actually, a carrier is a person who does not have the symptom, or only has a mild symptom, because it depends on different genetic conditions and genes. But they carry only one copy of the not working genes, mainly for recessive disorder. Carrier screening, we're mainly talking about recessive disorder or sex-linked disorder. Okay, so most individuals do not know their carrier status prior to screening. That's why it's important to screen, right? Because you are only a carrier of a recessive condition. You don't have the symptoms, right? But why it's important? So if we take autosomal recessive disease as an example, you can see that if both couple are a carrier of the same disease, right? As we can see here, right? If, let's say, for the red color one from the woman and the black color one from the man is the carrying the affected not working gene, you can see that there is a 25% chance of this autosomal recessive condition that could be passed to the next generation, right? And actually, this become even higher in a sex-linked recessive condition. You can see that if the mother is a carrier of the sex-linked conditions, you will only always have the sex-linked disease from the mother. Why? Because the father will only contribute for the Y chromosome, right? And if there's another copy of the X, then they are carrier, they are not affected, okay? So with that, for a boy, because you only get the affected X non-working chromosome from the mother, so actually you have a 50% of the boys that get affected. So with these two scenarios, that's why it's important we are going to screen for autosomal recessive and sex-linked disorder. Okay, so we need to consider when we going to the expanded carrier screening. First is the medical history and the family history of the couple. For example, as I mentioned, in a locality where alpha and beta thalassemia is very common, or if they already in the family, you see a lot of mental restrictions, among the male siblings, they may be related with Fragile X. Okay, this is the kind of meaning of medical history and family history. Okay, the other thing is incidence of the rare disease in the locality and population, right? For example, cystic fibrosis is less common in the Chinese. So this is another example of what we mean by incidence of a rare disease. And then turnaround time is important. Why? Because as we mentioned, this could be offered for couples as well as ongoing pregnancy. If it's already in ongoing pregnancy, you are not able to have results in the early pregnancy, then you cannot do prenatal diagnosis. So that's why turnaround time of the test is also important. Other thing is limitation of the expanded carrier screening. What it means is that because some of the genetic conditions, it is not just by point mutation, single nucleotide variant. It could be a region is deleted or duplicated. So if the test you order, they only take care of point mutation, then it's not comprehensive. It's not good, right? For example, particularly for alpha thalassemia in our population, most of them is copyloma changes. It's not by point mutation. Other consideration is that depending on pregnancy, are they go for IVF or natural, or are they going to consider for prenatal or pre-implantation genetic testing? Insurance policy is also important because once you order the test, the result is there. So is it, if this is already a genetic risk, were they excluded from the insurance policy? So these are all need to be considered. Right? Ethical issue as well as law, because of the religious issue and local law as well. Okay, so what's the criteria for carrier screening panel? Usually we are care mainly about autosomal recessive as well as sex-linked disorder, as I meant to you, because they expect to have significant clinical impact and mobility during an individual's lifetime. Okay, and also we only screen for things that their intervention is available and alert the clinical outcome, right? Because like you don't want to tell someone that, oh, you're going to die in a month, but then there's nothing you can do. And what's the point of saying that? So the same concept for carrier screening. And we also care about high frequency of expected carrier in the population. Because if it's too low, there's no point to screen, right? Screening is mainly applied for, a disease that's highly prevalent in our population. The other thing is, of course, the availability of the cost effective, but also the reliability of the test. Okay, is it a highly positive predictive value? It's a good detection rate and have a low false positive rate. So that's why usually we refer a test to a accredited laboratory because you are able to ensure the reliability of the test. And also because it's accredited, no matter the patient bring the report to you or to another clinic or internationally to another country, it's recognized. They do not need to perform the test again. And also the appropriate access for the patients to genetic counseling and informed consent. Okay, it's very important. You need to be informed consent, right? And also offer pre-test and post-test genetic counseling because it could be a lot of things happen with unexpected, right? The most easy way you can think of unexpected is non-paternity. It happens in our center. Okay, so these are all important concepts you have to bring and share with the patient. And also the voluntary participations or requests by the patients. Okay, we cannot force the patient to do a test if they do not. Okay, so you see the new thing is not, actually you can see that the American College of Medical Genetics and Genomics already issued a position statement regarding prenatal and preconceptual expanded carrier screening in 2013. And it's mainly because within different populations, we have a lot of autosomal recessive conditions that I just highlighted to you. Because if both the dad and the mom is a carrier, right, you have a high chance, no matter autosomal recessive or sex-linked disorder, that you can pass the conditions to the next generation. So these two slides are very useful for you when you can use it to explain to the patient and the Ruth route how it was transmitted to the next generation when you need to use that to explain to your patients. Okay, and carrier screening for monogenic condition is really, have been a standard for a long time. You can see that back in 1963, PKU screening has been available. And then TISAT screening for individual for the Scandinavian juries as early as in the 70s. And then it comes in with the cystic fibrosis because it's more common, in the European populations, and also, Fragile X as well. And you can see that some of them is, as I mentioned, could be because of the drive of the technology. You need to be a very cheap, high throughput test. So that's why Fragile X takes longer, because Fragile X, you need a much better approach than the old day you do a self-test. But is this a concrete evidence the need for the screening? Is yes. This is a study. I bring it as an example. That's from the Italian group. You can see that the increase in the number of screened carrier over time can show a significantly correlated with the decreased cystic fibrosis birth incidence in Italy. Okay, and it's not just for cystic fibrosis. The other study also showed that thalassemia carrier screening can help to reduce the incidence of beta thalassemia from originally 1 in 250 to 1 in 4,000 in Italy. So that shows you the importance and how useful of a carrier screening in terms of public health in the population. And that's why it's becoming more and more popular and more influential in our daily practice, no matter in which fields you are, because all these genetic conditions could be related with metabolic disorder, hematological conditions as well. And even, there are some related with cancer, like BRCA1 and BRCA2. They are very common in your African population. Okay, so for consider the clinical practice, as I mentioned to you, there are several points you have to consider. Pre-test counseling, right? Patients have to know what they are testing, right? You also need to understand the scope of the test. Post-test counseling, when they receive the result, even as negative, does it mean there's no risk or it's only reduced risk? We also need to involve the assist reproductive team, because if they are carrier, they may want to have options of IVF with pre-implantation genetic testing, or they may want to go for a natural pregnancy and then go for prenatal diagnosis. And all the time, clinical geneticists play a very important role to explain not just the mode of inheritance, but also, the importance and the pathology of the disease. And we also need to involve the obstetricians as well as the pediatricians as well. Okay, so I think there are several key components I want to go over with you. I think the first question is that with all this information, then who should be offered, right? Are we going to screen for everyone? Or is there any particular group we have to be very cautious when we offer this test? Okay, so who should be screened, right? There are many guidelines, right? No matter from the Genetic Society, even from our OG Society. Okay, so I try to summarize as a general summary, right? It doesn't reflect necessarily this is, but this is more like the common practice. Okay, so the first is that, okay, who should be screened? Okay, if you look at the common bulletin points of all these guidelines, first is that it's generally recommended, okay, this information about genetic carrier screening should be provided to every pregnant woman, okay? After counseling, a patient may decline any or all the screening. Okay, remember, we offer, it doesn't mean that they should take up all, or we offer them a big panel of genetic screening, they may only want to take a small one. Okay, and carrier screening and counseling ideally should be performed before pregnancy, because that gives us more time. Okay, so with that, actually for preconceptual screening is recommended over prenatal screening, because as I mentioned, it gives more time, not just for your intervention, but more time for the patient, or you should call them a subject to consider as well. Since it may be less stressful on patients with positive screening result, and it also allows for full complements of reproductive decision making. Okay, if done in pregnancy, concurrent partner testing should be offered. Okay, it's very important, right? Because if already ongoing pregnancy, you screen for one, and then you need to wait for another round for the partner. It takes too long. Then you may not have a prenatal diagnosis option. Okay, and when a reproductive partner have changed, carrier screening should be readdressed. Okay, because if your partner changed, the genetic background is different, right? So that's why you need to always retest for the partner, not for yourself first. Okay, so after understanding who should be offered, then how about the conditions and the genes? How many of them? Okay, and how comprehensive should we offer? Is there any guidelines, or we just say, oh, I just based on today's lecture, then I offer you this? No, there are recommendations and guidelines. But first, the basic principle is that disorder should be of a nature that most at-risk patients and their partners identified in screening program would consider having a prenatal diagnosis to facilitate making decisions surrounding reproduction. Right? As I mentioned to you, you offer screening, you need to have solutions, right? It's not just screen, oh, you are high risk, there's no option, right? So that's why they should be able to follow at least by prenatal diagnosis, if not by pre-implantation gene testing. The inclusion of disorder characterized by variable expressivity or incomplete penetrance. That means if the disorder, when they have the mutation, they are not always have the same severity of the disease, or the one with the mutation, they may not have the phenotype at all, or those known to be associated with a mild phenotype should be optional, okay, and make transparent when using this technology for screening. So that means they are not the prioritized gene list that we should consider, because you can see that even for counseling, it's very typical, right? When they have it, then they ask, right, what should I do for prenatal diagnosis? If you do a prenatal diagnosis, this mutation only have a penetrance of 10% or less, then how we handle it? That's very difficult. That's why, pre-test counseling or post-test counseling with a carrier result is very important before they go for the next option. Okay, so this recommendation is guided by the ethical principle of non-malignancy as well. That means, it's the principle of that you give the best benefits for the patient for your care. Okay, so to summarize in one word is that which gene and condition is that the incidence of rare disease in your population and your locality is one of the most important things to go to consider when you consider the test, right? Okay, how about adult onset disorder? Okay, disorder that could affect the offspring of the individual undergoing carrier screening once the offspring reach adult life. We consider those as adult onset disorder. Okay, they are included in most of the commercial screening panel. So patients must provide consent to screen for this condition, right? Because their age of onset is later, so they need to know that they are screening for those, especially when they may be implicated for the health of the individual being screened or other family member. Okay, because it does happen that although they come for a screening, but themselves is an adult onset genetic disorder, just that they have not onset yet. So actually, it come up as a diagnosis of an adult onset disorder. Okay, so that's a possibility. That's why you have to explain this to them as well. So this recommendation follow the ethics principle and the anatomy as well. Okay, so because this will be, a psychosocial, legal, and insurance coverage issue. Okay, so they have to be aware of that. Okay, so what disease? Okay, in principle, as a general principle, so I purposely have this in Chinese and English, is that, okay, we are taking about those that have a high frequency. So what's mean by high frequency is 1 in 100 or quicker, okay, and have a well-defined phenotype, have a very, detrimental effect on quality of life, because cognitive or physical impairment. And this will require surgical or medical intervention or have an onset early in life. Okay. Also, additionally, we screen conditions should be able to be diagnosed prenatally. Okay. And we can offer opportunity for antenatal intervention to improve perinatal outcome and change the delivery management to optimize the newborns, okay, and the infant's outcome. Okay. Carrier screening panels should not include conditions primarily is associated with a disease of adult onset. Okay, so the key factors here, they have to be high incidence, they have a very clear, diagnosis, they are severe, they are early onset, and they were able to be intervened. Okay, so how we make a condition is severe, it we group as profound, right, shortened lifespan, okay, severe, death in early adulthood, moderate neurosensory impairment, okay, or mild, that's not meeting one of these above. Okay, this is how we define, okay, the group of disease, then their severity that we're going to do. Okay, so for each disorder, the causative genes mutation, or as well as the mutation frequency, should be known in the population being tested, so that meaningful residual risk individual who test negative can be assessed, right? Because sometimes we test for all this, but we know that some of the genes, they may have other mode of mechanism. So we know that there are still possibilities. So for example, for the Fragile X, if we do all the repeat sequence, there are still 1% of the chance they can have a point mutation. Okay, so this is a scenario, an example, what we mean by, individuals' residual risk. Okay, so laboratories should specify in their marketing literature and test result how the residual risk was calculated, right? Using what population, or is it a specific ethics data? And the calculation of the residual risk require knowledge of two factors. First, the carrier frequency within a population, and the proportion of disease-causing alleles detected, the specific test platform. Okay, so what this means is that, okay, because when they test the gene, they may not test for everything. So that's why, right, the proportion of disease-causing allele, right, with the specific platform, this is the meaning of that. Okay, so laboratory using multiplex platform often have a limited knowledge of one or the both factor. Okay. Other thing is that the laboratory offering expanded carrier screening should keep data prospectively and regular reporting findings that allow computation of residual risk estimated for all disorder being offered. Because sometimes the mutations may be reclassified from pathogenic to variants of unknown significance, or from variant of unknown significance to be pathogenic, or to be benign the other way. So that's why this is important. So when data are inadequate, patient material must be stressed that the negative results should not be overinterpreted. Okay, so regarding the list of conditions, okay, there are, as I mentioned, there's a guidelines, okay, and usually they are divided into tiers. Okay, so what I mean by tiers, right, is that the first tier is those they are recommended by the ACMG and the ACOG guideline. Okay, for example, cystic fibrosis, SMA. Okay, tier 2 is those that have a high frequency of 1 in 100. Tier 3 is those that have a frequency in 1 in 200, etc. Okay, so that's why they are divided into tiers. So any recommendation, what tier to be used? Okay, so you can see that for the ACMG, okay, they recommend all pregnant patients and those planning a pregnancy should be offered tier 3. Okay, they does not recommend only offer tier 1 and 2. It's because this does not provide equitable evolution of races. What it means is because some of the disease in tier 1 and 2, they are more confined to one population, but not others. But now actually, I think we see more couples. They are from different ethnic group and backgrounds. Okay, so if you only offer tier 1 and 2, they are not good enough. And in our center, actually, we offer up to tier 4 for our expanded carrier screening. Okay, so you have to understand whether you're going to offer for the minimal or you're going to offer more. So if you offer the minimal or you offer more, what is the main challenge, right? The main challenge, one of the challenges is that there must be a validated clinical assessment between the mutation detected and the severity of the disorder. That means patient and provider material must include specific citation that support the inclusion of mutation from which the mutation is being performed. Okay, and also they need to be compliant with the American College of Medical Genetic and Genomic standards and guidelines for clinical genetic laboratory, including quality control and proficiency testing, This QC should include the entire test process, including pre-analytical, analytical, and post-analytical phase. That means including validation of results. And the performance characteristics should be available to patients and provider assess. Right, test performance, as I mentioned to you, is the scope of the test, right, as well as what they included. Okay, so for the P-test, it may not be practical for clinicians to discuss each disease included in a multi-disease carrier panel, right? Because like in our center, we are test for 302 conditions. Okay, so if one condition, you need to spend 10 seconds, still quite a horrendous amount of time. So that's why it's not practical to do that. But an appropriately tailored information pamphlet or website containing a brief description of each disorder included in a test panel should be available to patients undergo or considering an expanded prenatal or preconceptual carrier screening. Okay, genetic counseling before testing should be available for those who desire. Okay, so it's not necessary to have a genetic counseling, but pre-test counseling is important. Right, it's not very detailed, but at least this is the information you should do. Plus, you have to share with them the limitation of the test and also the implication of a negative result. Okay, and the type of variant to report is also very important, right? Because in most of practice, we only report pathogenic and likely pathogenic variant. But I see some of the report in China, they report so many things, a lot of variants of uncertain significance. Is all in their list. It is not necessary because it doesn't help. Right? It makes more worry as well. And also interpretation should consider gene and variants with multiple gene associations. Okay, so sometimes one gene, a single mutation can have different phenotype as well. So this is what it means. Okay, the report of VUS variants of uncertain significance, when we do that, is only in the partner of identify the carrier and only with consent of the patient. Okay, that means, right, if, for example, the partner have gene A, that's a pathogenic, right, and then he or she will test on the same gene, okay, then you find a VUS. Then at that scenario, we may report. Because like in my last lecture, the VUS may be pathogenic, but just there's a lot of evidence that may be helpful. But you don't liberally report all the VUS, as I mentioned here, only when the partner already have a pathogenic one, okay? And then for post-test counseling, disclose of the mutation detected, description of the clinical nature, including the natural history and the management of the disorder in question, facilitation of testing of reproductive partner, calculation of the revised fetal risk when the partner is not available for testing or declined testing is important, because that we're able to help whether drive the partner to go for the test, or is it necessary for the partner to do the test? Identification of other family member at risk of the disorder. Sometimes it's important that help you to trace the penetration of the disorder. And discussion of options for fetal testing and reproductive discussion making. These are all important for post-test counseling. Okay. Then for VUS, all right, if you really report, is there any guideline how we report? There are not a lot, but I take this is from the, this is from the UK, from the Association of Clinical Genomic Science. They give a scale, okay, because that would be better, right? If you are able to give a scale of VUS hot, right, that means it's strong with some support or moderate support to a really, warm or cold one, then at least the patient or a clinician, they may understand more about, how important or how significant is this VUS. So this is just an example, right, for you to reference. Okay. So another point to note is that that's more with the insurance issue. You can see that the Genetic Information Non-Discrimination Act, GINA, makes it illegal for most health insurers to require genetic testing result or use result to make decisions about coverage, rate, or pre-existing condition. But GINA also makes it illegal for employer to discriminate against employee or applicants because of genetic information. But this does not apply to life insurance, long-term care insurance, or disability insurance, right? So this is what have been suggested by this GINA. But in Hong Kong, we don't really have a good system at the moment. may in your country you may have it, but I think this is also an important piece of note. When you do the test to share with the patients, right? And actually, this is not just applied for expanded carrier screening, because now we have more patients. They will test for exon sequencing or genome sequencing. So when you do exon or genome sequencing, you will also see more than just this, using expanded carrier screening as an example. Okay. So with that, I would like to conclude the first part, give you an overview and points that you have to pay attention and care about that. Okay. So I will go through a few cases for discussion, and I will leave some time for Q&A. Okay. So for case discussion, case one is very straightforward. What I want to show you is that, okay, this is a test. It's a commercially available test. And most of the commercially available test report is similar as that. Okay, it tells you first what you are testing. So this is a sequencing analysis plus deletion and duplication testing of 301 genes listed in their panel. Okay, and the reasons for the test is a carrier screening. Okay, and you can see it come back as a positive result. Okay, so just a general knowledge, right? In our populations, if you test for 301 gene conditions, what do you expect your positive rate among 1 in 10? Okay, no, you are a genetic counselor, it keeps you less busy. Anyone can give me a better guess? No, right? If a patient pay for money to do a screening, that means those are really high carrier rate, right? So actually, of course, this will also depends on your patient group, right? Are they IVF couple or they are in general population? So in our center, they are mainly referred from IVF couple or couple already have unpleasant family history. It could be as high as 65%. Okay, and some group can go up to 80%. So you can see that it's very high. Okay, so and that's another reason that usually their ongoing pregnancy, at least more than 65% will be a positive result. Then their partner should be do concurrent. You shouldn't wait. Okay, so this is the first thing. Okay, so for the positive result, the most important thing we want to know is what are they? Okay, are they very important? Okay, so first for the result, they will tell you the condition. So this is a congenital disorder of glycosylation. So it tells you the name of the gene and also the nomenclature. This is a standard nomenclature. So you can see that there is a codon change or with a nucleotide change at 430 at a T to C, which leads to a amino acid change. Okay, and this is an autosomal recessive condition. And they also say that the partner should be recommended for screening. Okay, so it's very important to look at these two information. Okay, so once you have that, actually, they will also give some explanation. Right, first, this diagram is important because you can share with your patient that, oh, you know, you are already a carrier. So if your partner needs to screen it, because if he is a carrier, then there are 25%, right, of them is affected, okay, or the children could be a carrier like you as well. So this is helpful. And then there's also information to share with you what is the condition so they can understand. Okay, so with that, okay, if it is a negative results, okay, then you can see what is the residual risk, okay, and it also tell you the carrier frequency in their populations. Because it's so high, that's why it's quite easy for these subjects to get a positive result. Okay. Okay, and so every gene conditions they screen, they should be able to give you the carrier frequency as well as the residual risk based on your ethnic group. Okay, so this is the information which will be helpful for the patient. You can see, it will tell you, is it a panetics or is this related with a specific population? Okay, so for this case, what we need to do for the post-test counseling is that we need to disclose the mutation. We need to describe the clinical nature, including what I just mentioned, and also the disorder. Okay, facilitation of test of reproductive partner, because the calculation of revised fetal risk with the partner is very important so that they understand whether they're going to do it. Okay. We do encounter their partner, they decline. Okay, it's not necessary you say you have to do it, their partner will do it, they can also decline. Okay, so identification of other family members at risk for the disorder, right? Some of them, as I mentioned, that's more related if you identify they are affected, right? And also the discussion of the option for fetal testing, right? So that's more like if the partner is positive, then what's the options in the future you may have. Okay, so that's case one. It's a very general one. One thing for case one is that, do you think a lot of the subject, they will only have one condition? Or is it common that you have more than 2 or 3? Actually, it's common, right? But it's not like you go and buy Mark 6, right? You go and buy Mark 6, oh, good, I got more. You're happy. But when you got more, actually, you are not happy because you have more risk, right? But it happens, right? Right. So like in the second case, you can see this is a second case, test for the same, but you see this is a couples, they come to clinic at week 18 already. So usually expanded carrier screening results come back in 3 to 4 weeks. So you can see if you have a results, then if the partner have not been done, another 3 to 4 weeks, it's already week 22. It's too late, right? Because when the results are ready, you may not have the resources to do the test in the next day. So you still need to allow the time for the couples to think. You need to allow time for the clinical geneticists to see them. So that's why for ongoing pregnancy, we always recommend concurrent, right? It's not good to do one by one because it's really, you don't have much time. And you can see that for this subject, right? It carries the TJB2, which is a autosomal recessive hearing loss gene. Okay, it's one of the most common mutation in Hong Kong Chinese as well as in mainland Chinese, this one. But the problem for this one is very low penetrance. Okay, it's not complete penetrance. Other T6PD is also very common in our population. This is a sex-linked disorder. And also there's another more rare conditions with autosomal recessive, it's a frame shift, okay? So you can see that these subjects have 3 genes with a mutation as a carrier. Okay, so if you look at the GJB2, you can see that the change is less likely to result in symptom. That's why I say it's a low penetrance. Okay, so in this scenario, actually, if they have a positive, that's why before the testing, you have tell them if you screen for GJB2, actually, in Hong Kong, at least in our center, you are not entitled to do IPGT, no PGTM. We don't recommend, we don't support PGTM or GJB2101. Okay, homozygous, right? Heterozygous is a different. Okay, so this is the information you need to be aware. Okay, and then for G6P2, we have to clarify, explain that this is a sex-linked pattern. Okay, and it also could be with X inactivation. Most of this information, they are available in the report, okay? Because of time, I'm not going to go too much in detail. Okay, and also some of the genes, they have a pseudo deficiency effect, okay? So they may exhibit a false positive result on related biochemical testing, including the newborn screening. So these are very important information that is helpful when we do the counseling, okay? So with that, of course, the husband have to go for the test, right? So the test come back, you can see this another gene, okay? So CFTR. So based on this scenario, okay, if the sex-linked disorder is not important, then actually there's no intervention is needed. Okay, it's just that the background genetic information of these 2 carriers you have to explain. Okay, but CFTR is important because it could be related with infertility. So the important thing is that we need to know what's the variant, okay? And you can see that this is a homozygous variant. Okay, so you can see that for this particular repeat region, it's ranged from a healthy individual to with a KUFA in male with an individual with a mild atypical CI. Okay, so with this information, what you need is that you need to have a clinical evaluation with a primary care provider. So this is the information you have to give to them. Then for the other is more on the pseudo gene issue, I'm not going to talk. So you can see that each case could be very different scenario, different things you have to take care of. So this is the last case, that's case 3. Okay, this is a 32-year-old woman. The husband have good past health. They are on IVF protocol. Okay, on one episode of miscarriage and 7 weeks, has unknown reason of infertility. They have 10 embryos were frozen. Okay, so whatever you have the result may affect what they're going to do with these 10 embryos. Okay, so for this one, you can see that herself is related with alpha thalassemia, right? We got a deletions and then an autosomal recessive condition. And she's also with a CFTR. Okay, so 2 genes were affected. Then this is her partner. Okay, you can see that her partner also have the CFTR. Remember they're infertile couple, okay? And then actually he has 2 mutations in the autosomal recessive condition. So what's the issue? The issue here is that these 2 mutations on one allele of the gene, or they're in the 2 allele of the gene, because it will be very different, right? They can be still as a carrier or as an affected. Okay, so that's why these are the information we have to pay attention to. Okay, so the post-test counseling is first, we need to explain for the residual risk. Okay, so for the thalassemia, and you can see that it's very common in the populations. And then because she's a carrier, so we have to pay attention on that. But how about the husband? Okay, if there's no indication with a low MCV, probably there's no other where allele carrier, that's okay, it's clean, right? So if there's no, the concern is more on the CFTR variant, right? Remember the wife had 1 and the husband have 2. Okay, so as I mentioned, it could be ranged from healthy to have issues related with infertility. Okay, and if you look at the literature, we know that both of them are pathogenic. Okay, so with this information already known in the literature of the pathogenic, okay, what we do first, we also need to update from the literature. So you can go to this website. This is from the quinoa. So you can type in the mutation again, and give you more updated information. Okay, on how many reports and everything. This is just give you an example, right? And you can always see that they have the submission date, so you know that how they was updated. Okay. So the problem here is that when we do the counseling, we need to know if the husband is on, as I mentioned, both mutation on 1 allele, or they're on 2 allele. Okay, so there's a need further information. So what's the best way to do? How I know that it's on cis or trans? Of course, if it's pathogenic, then you may have the disease, right? But if the disease is a late onset, then you're still not sure, right? So the other way is that you ask the husband's parents come to do the test. Okay, then it can help you to know that this is in trans or cis. Okay, this is why sometimes we need to ask for extended family member. This is where we are. Okay, so we need to explain the possible outcome of this embryo combination, cis versus trans, and also the phenotype of the different combination. Okay, and then we need to discuss whether pre-implantation genetic testing is feasible or ethical, right? Because the woman's is already have 1. Okay, so the results of this genetic workup is very important, and to determine what test they need to do. Okay, so that is the 3 cases. So I'm going to summarize some of the experience from our center. Okay, so these are 2 earlier publications. So you can see that, as I mentioned to you, if I test for 100 conditions, or we test for 11 conditions in 2 different populations. One is IVF couple, the other one is early pregnancy woman. You can see that the less condition or gene you test, actually your carrier rate is less. Okay, and you can see that over 100 is already reached 58%. That's why it's a lot, right? So for a genetic counselor, if you need jobs, so you want to do more things, you may ask your patient to order a big panel, then you keep you busy every day because there's always case for you. But is it ethical, right? That's a problem, right? Okay, but if you look very carefully into in terms of the disease, it doesn't make a big difference, right? You can see that because we know in our lower population, alpha and beta thalassemia is most common. They are still the top in the list. Okay, so what this means is that the value for money. Okay, if the 11 genes is only $10, the 100 gene is $100. Is it worth to pay 10 times more to do more, or we do less. This is more related with public health issue. Okay, but that give you a very nice scenario to explain and what you see here. Okay, so with that, this is why we offer and confided to 302 condition panel based on the publications and as well our local data that we are now offering in Hong Kong. And we believe it is a very useful test and is offerable for patients. Okay, and what you need to be aware is that you do from our center or other is the same. Is it a target genotyping or NGS based? Because as I mentioned to you, that will be different in terms of the coverage. Are they on coding region plus the adjacent intron sequencing region or even the copy number variant? The other important thing is the calling. Okay, how they do the curation. Are they also report benign, VUS, or pathogenic? Right? How this is implemented in the report. These are the things you have to consider when you're going to run the program in the center. Okay, and at the moment, apart from self-finance, actually we also collaborate with the Jockey Club to offer this genetic carrier screening program for high-risk couples. We provide free pre-genetic test assessment service for eligible patients before pregnancy, and also offer this test for free if appropriate, including the expanded carrier screening with Fragile X or chromosome that's more related with copy number changes or chromosome balance and imbalance translocation. So the information is here. So that gives you a favor of what we have learned over the last 10 years and get it to be implemented as a self-finance as well as a public program that's going to help with the others. So the take-home message for this lecture is that for expanded carrier screening program, if you want to implement, pre-test education and consent should be broadly described, the type of conditions being screened, as well as the limitation of the screening. Educating patients before testing may be done verbally or by using other information approach, such as pamphlets, videos, or online resources. Pre-test counseling should address the following general concept. First, the choice of the expanded carrier screening, autosomal recessive and sex-linked disorder. Screen negative results only reduce the likelihood of the carrier status of condition, but a residual risk of being a carrier always remains. Some of the conditions screened have less well-defined phenotypes. Some conditions being screened are rare. Disease prevalence, mutation frequency, detection rate may be imprecise, and residual risk estimation may not be reliable. Why is that? Is because we have keep on updating with literature and methodology. So that's something you need to bear in mind. Screening panel may change over time, and there may be differences between the laboratory in the condition screened. Right? Even take cystic fibrosis as an example. Some lab they screen for more than 50 mutations. Some lab only screen for the common 15 hotspots. Okay, so you have to be aware of those. Right? Possible implications to emotional, psychological, social, finance, legal, insurance issue. You have to be aware and let the patients aware as well. For post-test counseling, implication of results is important to explain. Reproductive choice, no matter prenatal, pre-implantation, as well as worst case, egg or sperm donation and adoption should be explored to them as well. So with that, I would like to conclude my talk with some references for your references. So that's about it for my talk. Thank you for attending.